Okay, so we're going to go ahead and get started, and we're going to talk about osteomyelitis. And most of you know that most of the osteomyelitis uh, is going to be in when you're doing our team, because basically in Tampa General, most of the osteomyelitis have most of the cases are going to be associated with a private team. So that's why we're going to be talking about this. And actually, you're going to get some articles, and I encourage you when you come to our service in the week that you do osteo, that you read those articles. It's interesting, and one of the things that I always tell people about being a consultant is learning about the subject. Like, you can never be a good consultant with orthopedic surgeons if you don't understand a little bit about what they do. Just like you cannot be a good transplant ID if you don't understand basic transplantation. If you're interested in a part of ID, one of the things that you have to really work hard is understanding what the person you're consulting with does, so that you can understand their problems, their limitations, their abilities, on all those things, and you respect what they do a lot more. So I have always had an interest in osteomyelitis. So one of the first things that I did, and when I started my ID consult career, was that I actually went to orthopedic meetings. I wanted to learn what orthopedics did so that I would understand their lingo, what they talked about, what were their problems, and that helped me relate to them. And that's why I have a great relationship with all of them, because when they talk to me, they know that I understand what they're saying and that I understand what they can and cannot do. So you're not going to be asking somebody to take hardware out of a spine that is not fused. Hello, it can't happen. Stability is above infection unless you can put an external fixator, you can take out something. So anyway, so there are basically two classifications of osteomyelitis, and we're going to go through both of them. I'm going to go through this one because this is the most common one. The other one is Cerny matter. So you need to be familiar of both classifications, but this is the one that we use most commonly. This is the one that most people we'll talk about. There's the other classification, which is not as common, but you need to know about it. So basically, when you talk about osteomyelitis, you haven't said anything yet. You have to say, okay, are we talking about hematogenous osteomyelitis? Are we talking about contiguous osteomyelitis? Are we talking about peripheral vascular disease? Or is it something associated with one of the specific problems, whether it may be prosthetic joints or septic arthritis, or the problem of open fractures, tenosynovitis, septic bursitis, or pyomyositis? And these are terms that you actually will use. Like, Marela, didn't we have a pyomyositis in the emergency room? Was there any other term to use in that case? No, it was a pyomyositis. As a matter of fact, we have had two pyomyositis in my service recently. We have a Staph aureus pyomyositis, and then not MRSA, regular staph, and we have a group A strep pyomyositis. Have you ever seen a case of pyomyositis? You may not. I have two. You probably have in Miami. So we have two. We have had two cases of pyomyositis acute in my service for the two most common organisms. One was group A strep, the other one was Staph aureus. And actually, it was funny because we were called to the emergency room because the patient had trichinosis. Pyomyositis. It's actually rather funny. So anyhow, so you're going to be seeing prosthetic joints, a very specialized area which we're going to talk about, part of the lecture. So in general, we're going to talk about all of this in general, but then we're going to talk a little bit about prosthetic joints. We're going to talk a little bit about septic bursitis. We're going to talk a lot about open fractures, because I noticed in some of when I am rounding that some of you have very little knowledge or what's the problem with open fractures. So I actually added to my talk some stuff about open fractures, because you obviously, and it may be that in internal medicine, you don't get to do much, and since the USF does not have a good orthopedic program in the past, I mean, they're working on it, and hopefully you'll have a little more exposure to some of these things. So that's why I added some of that. So hematogenous osteomyelitis. Hematogenous osteomyelitis happens at any age. In children, usually it's in the metaphysis of long bones. So you'll see them very commonly on the femur. Kind of like long bones are very common. In neonates and infants, it's kind of mixed up with septic arthritis because there's no difference in the arterial circulation. So they, like, you'll see the whole joint and the bone in and up, which is the most horrible thing to see in like a neonate. Like, you get called to, and we don't do that anymore. But the problem is that knowing a little bit about PIDS ID is important, especially if you're not in a academic institution, because if you're in San elsewhere, I can tell you that you're expected to know a little bit about PIDS ID. In the past, like for example, when I did my fellowship, we had to, the ID boards required understanding PIDS ID, because back then there was not a PIDS ID board separately. It was just ID boards, and part of that was PIDS, so we always had to learn about PIDS. And it was not until Patty Emanuel came around that actually we had to, you know, we had some PIDS ID on its own, and for a long time, I did a lot of it myself. So children, metaphysis of long bones, neonates, and in adults, hematogenous osteomyelitis is in the vertebral bones. And this we see a lot. I mean, understanding vertebral osteomyelitis or discitis is something, it's like an ID 101 issue and what to do with it. Most common one at lumbar, and but you can see in lumbar, thoracic, or cervical. Lumbar is more common, but the other ones are just as common. The good thing about this is that this is a chance in which osteomyelitis can be cured. And you know, talking about cure and osteomyelitis on the same sentence is a rare event. Most of the time, we do not use the word cure and osteomyelitis. But in hematogenous osteomyelitis, you have a chance for cure. So it's an important thing to diagnose correctly, and to treat correctly, because you have a chance to cure the person. So actually, the person is going to have exquisite pain, and you're going to have a lot of tenderness over the area. Moving the area will be very difficult. Some patients have fever, and actually this is one time where the person really has weight loss, night sweats, fever. Actually, the person looks ill, and obviously in sickle cell, you have to differentiate it with a sickle cell crisis, and the neonates and children, a lot of times you have like a pseudo paralysis. If you see a 1 or 2 year old that doesn't want to walk, that was walking already, you know, you always have to rule out osteomyelitis. That is a very common presentation in children. In adults, you have exquisite pain. A person that says, you know, I have never had back pain, or I have chronic back pain, but this pain is out of my mind. That is different. When you have these acute pains in the setting of fever, or in the setting, that is something that you have to be very concerned about. And when you examine them, they have pinpoint tenderness over the area. What are the people that that are high risk in adults? Obviously, sickle cell, because you know they have infarcts. Hemodialysis patients, because they have an entrance to their bloodstream constantly. IV drug abusers as well. So anybody that has had some kind of infection in the blood, like we'll see a person being in the hospital for whatever, a prolonged illness, that person gets better and goes home and then comes back with a discitis. They probably got seated at the time of the hospitalization, and they come back with the problem. The most common organisms are going to be staph, is going to be very common. Haemophilus influenza, especially in children. Gram negatives is not uncommon, especially on patients that may have, for example, an enlarged prostate, or they may have had a problem with a UTI that seated the back. Anaerobes are rare, but it can happen, especially in diabetic. You may have something like a propionobacterium. You may have whatever, which occasionally occurs. A mycobacterial disease, especially vertebral osteomyelitis with mycobacterium, whether it may be tuberculosis or atypical tuberculosis. Like right now, we have a suspected atypical mycobacterium in rehab from a patient, and a transplant patient. So these things do occur. I have taken care of several HIV patients early in the epidemic with, which actually I'm taking care of still, but that they had MAI in their back. At least I have 3 of them that had MAC in their spine. Tuberculosis of the spine in HIV patients I have seen. Tuberculosis On other patients in the back, you see them. Obviously, everybody knows that Eleanor Roosevelt had Pott's disease. I mean, that's a well-known fact. So these things are not unusual. The other big thing is whenever you have a discitis, you always have to rule out tuberculosis, because usually the reason why the vertebral bones are infected in adults is because there's some disruption. The person has had some disruption in some chronic changes. So anything that disrupt that the vasculature or any chronic changes in that area, when the bacteremia occurs, it gets seated, which may be in sickle cell because they had infarcts. It may be in adults because everybody has back pain and it's a wear and tear area of the body. Tuberculosis may be another reason. So the pathophysiology of how hematogenous osteomyelitis occurs is actually the same everywhere. You have the child that without realizing it was in a bike and fell and kind of hit the little leg, and he didn't remember. He got up. You know how kids are. They just bounce back. And nobody remembers that anything happened bad to them, but now they became bacteremic and they seeded. And nobody remembers the little injury that they had 3 weeks ago. In the adult, they have tuberculosis, or they have chronic back pain, or they have whatever. So basically the pathophysiology is the same. You have some disruption in the bone, whether it may be long bones in kids, or the vertebral bones in adults, and a bacteremia occurs somewhere else and it seeds that area, and by the time it shows up, nobody's going to remember about anything else. So vertebral bones in the spine in adults, rule out tuberculosis, and about any organism may be involved. Actually, if the blood cultures are positive, it's great, and they may be positive in a lot of in about half of the cases. In kids, a lot of times they're positive as well in long bones osteo. The white count may or may not be elevated. The Z-ray and the CRP in these cases is usually elevated, but a low or normal one does not rule it out. Plain X-rays and an MRI are usually helpful. This is a case in which you want to do an MRI, especially in adults, to make sure that there's no neurological compromise. But there's nothing better than talking to the patient about making sure, that they have bowel and urinary, that they're not incontinent, that things are not advancing neurologically because of an abscess in the area. Bone scans, indium scans, all the scans. All of you that have, and I'll say it now, all of you know that my tolerance for bone scans, indium scans, and all the scans is non-existent. In my opinion, it's a waste of money in the majority of the cases. Well, you have had that experience with me. What I think about indium scans, it's a waste of money in most cases. Occasionally you order them, but it should be rare. Every time your hand is lifted to write bone scan on indium scans or any of these weird scans, you should be very careful, because those things are incredibly expensive. They delay the patient in the hospital for days. They take days to get done, and most of the time they're not going to give you any information that is going to change what you do. And if a test doesn't change what you're going to do with the results, please don't do it. But with that being said, in one of the few areas, and I cannot think of any other area of osteomyelitis where these scans may be of any use, they may be useful in hematogenous osteo. The reason why I'm saying this is because all of you are going to hear me over and over saying, be careful with indium scans, be careful with bone scans. But actually, in hematogenous osteo, they may have some role, and the literature supports it a little bit, so I'm going to tell you a little bit about it. But again, be careful not to overuse it. If you already have an MRI showing destruction, you don't need an indium scan or a bone scan. What for? But anyway, a bone scan, a three-phase bone scan, can be helpful in somebody that you worry about hematogenous osteo, and actually it may be most helpful, amazingly enough, in children. Now, if in an area that you have had a fracture, a bone scan, don't even use it, because I don't care how good the radiologist is, and you are. If the fracture has occurred, a bone scan is worthless. We're going to talk about how in diabetic feet and things like that is pretty useless as well. An indium scan sometimes could be the most useful in this setting, because the indium scan really does label white cells that are acute, and and it may have a little more use. But if you already have an MRI, you may not need any of them. Now, what is really important is not to rush into therapy. You know, tie your hands, make that pen disappear. What you really need is a bug. It is very difficult to do empiric therapy on hematogenous osteomyelitis. Remember, this is the only osteomyelitis that you're going for cure. You are going for cure. And if you're going for cure, you need to know the bacteria. The patient is stable. The patient does not have any neurological problems. You do not have to rush around. And actually, if the patient has a neurological problem, what he needs is a surgeon so that you can fix him and get a bug. So you really need to make that decision. Do I need a surgeon or do I need biopsy? And what we usually do is a needle aspiration, and we do 2 needle aspirations before we give up. You know, we do a needle aspiration, we send it through the bone scan, through the bone protocol, and the bone protocol at Tampa General is very well set up, where you do histopathology, AFB, and I'm going to tell you what the bone protocol is. It's safe for 2 weeks. I mean, you really have a chance of looking at the pathology, and the pathology is not only, you know, people always think, oh, no metastasis. No, I want to know whether they see something else. I mean, do they see granulomas? Do they have acute inflammation? How many white cells? We're going to talk about some of the bone biopsies in a minute. So the needle aspiration is important to verify that you have infection and to get the bug. So we may do 2 of them, and if that doesn't work, you may have to go to an open biopsy. But it's much better to make a diagnosis because, you know, the therapy of hematogenous osteomyelitis is long. And, you know, some of us that have been doing this for a long time understand and have ultimate respect for antibiotics. Antibiotics for 6 weeks are very difficult. Sometimes these people need more than 6 weeks. Sometimes they go up to 12 weeks. That is a very challenging event. Anybody can tolerate antibiotics for 7 days to 10 days. You know, the average length of a stay of a patient in the hospital is less than 6 days. You're not used to taking care of patients that are on antibiotics for weeks and weeks and weeks and weeks and weeks. Let me bring this news to you. Almost everybody on their 3rd week of IV antibiotics gets a complication. Is it the PICC line that gets infected? Is it the PICC line that gets a blood clot? Is it the white count that goes down? Do they develop a rash? Do they develop an elevated liver function enzymes, the creatinine, the white count, the platelets? Something happens. To commit somebody to wide spectrum antibiotics for a long term is not a good thing. Making the diagnosis early is a critical event. I cannot emphasize that. And on top of that, this is an area where, you know, it's disabling if you don't make the right diagnosis, and you can cure these people. So this is a huge responsibility. We need to make a diagnosis. Remember always that therapy, a monkey can figure it out. Your challenge as a good doctor is always to make the diagnosis. We're diagnosticians. We're not antibiotic pushers. That is critical, and over the next 2 years, you're going to hear this over and over and over again. Differential diagnosis, workup before therapy. Okay, so we're going to make the diagnosis, and the diagnosis is critical for hematogenous osteomyelitis. Now, because we are lumping hematogenous osteomyelitis not only the vertebral bone, but of the long bone and children, a lot of times, especially in kids, the hip joint may be involved. Or it may be involved in adults because you had a hematogenous thing and it went to a joint. The hip joint, if you ever have a concern about the hip joint, you need to do an MRI of that. The may needs to be aspirated, and you need to move quickly. Especially in children, that's a huge problem, because if you don't act quickly, you get a septic necrosis of that joint. That child will never be normal. So if there's any concerns, those kids, you know, the hip joint has to go to surgery very quickly, and I mean the same day. This is not the kind of thing that you can just round, leave recommendations and worry. That's not the case. This is where you get the stat thing, you follow it through, you call the orthopedic, you have to be on top of it. Obviously, for adults, neurological complications, and specifically you want to see what the motor and the sensory function, the urinary and bowel issues are. in kids, sequestra is a big problem, meaning that you have little areas of bone that are basically infarcted in the middle. They need to be cleaned up, and that sometimes is kind of like the circulation has broken, and you have like a little piece of bone, and you see, and that usually happens more in kids, but that needs to be cleaned up. And obviously, whenever the patient is not responding, that then you need to clean it up and also make sure that you have the right diagnosis. So poor response. So surgery is an important part in certain occasions of hematogenous osteo. Sometimes antibiotics alone can deal with osteo, but you always have to have that diagnosis first. Therapy. With hematogenous osteo, where there may be long bones or vertebral, or a septic joint that you have ruled out that there's no problem coming from anywhere else. And remember, because it's hematogenous, you want to do always a very good exam to make sure that this is not a systemic process. Make sure that, especially if there are positive blood cultures, whether the heart is involved, whether there's splenic problems, liver issues. So whenever you have either a long bone in a child or a vertebral osteo, and you want to make sure whether the blood cultures are positive or negative, and you want to do a good exam to make sure that there are no other systemic places or any other place in the body. All the other joints are looked at. You move your shoulders, elbows, hips, knees. You want to examine the patient to make sure. So then we have defined that we only have either the leg or the back, kids or adults, and nothing else is happening. If it's a hip, we send them to surgery. So now we're ready for therapy. So therapy is IV antibiotics for the specific thing, and it's high dose, meaning that you want to give full dose. Suppose that is enterococcus. What is full dose of enterococcal therapy? Our friend from Miami. So 12 grams a day. Great. And that's just for example. Oxycillin. How many grams? Q4, exactly. So this is now where we go little. So you want to do the right dose of antibiotics, and you want to put it correctly. And you're going to do high doses. You're going to do a minimum of 6 weeks. This is where actually we follow set rates and CRP, how the patient is doing. And a lot of times, especially on vertebral osteomyelitis, you have to go longer. And once they're a lot better, a lot of times we put them on oral therapy for 3 months or so based on what you have. Those patients, by looking at the set rate, by looking at the CRP and their pain, you can really get a feeling for what's going on. A lot of times, at the end of the 6 weeks, we repeat the MRIs, especially if they had like an epidural process or anything that looked like a surrounding abscess for resolution of that. You always know that the differentiation between in an X-ray or an MRI of osteomyelitis versus a tumor is that in osteomyelitis you have the disc, you have a vertebral and another vertebra, and in osteo you have the disc involved with a little bit on the top and a little bit on the bottom, erosion of the two vertebral bones. That's infection. If you have the pedicles involved, that's usually a metastasis. So by looking at plain film, by looking at the MRI, you have a very good feeling of what's going on in that back. And number two, you're going to make a diagnosis by getting the bug. Then you're going to be on IV antibiotics. You're going to follow, and the best opportunity is that initial therapy. So you have to make sure that you follow that patient, that you have the bug, and that patient is followed very carefully. In the old times, like there was no therapy for tuberculosis and for anything, kind of like cast and immobilization of anything usually helps the healing because it fuses it. The body helps it fuse. So that can help, but obviously you have to make sure that issues of deep venous thrombosis and things like that are not ignored, especially in the presence of adults. So you want to make sure that we still think about all the other potential complications. So that is hematogenous osteo. Let's talk a little bit about contiguous osteomyelitis. Contiguous osteomyelitis, the most common one is the one that is after surgery. But there are others related to soft tissues and puncture wounds. And then open fractures. I am not going to say much about open fractures because at the end of the talk I added like a whole section about open fractures because I realized from rounding with you that we had a little deficiency in this area that I wanted to fill in this year. So puncture wounds are very common. The typical situation is the construction worker that was wearing tennis shoes and stepped on the nail. The kid playing outside that stepped on the nail and the heel. For example, and you can have, obviously everybody thinks about Pseudomonas, but you need to get a history. Like, for example, not that long ago, recently, I had a kid that was 14 years old. He had a little aquarium ball, and the thing he broke, and then he stepped on it, and he ended up having Mycobacterium marinum in a toe because he stepped on it. Kind of weird, but it came from the fishbowl broke. He walked on it, so it was kind of weird. The cultures were negative. It was being done in a place where they couldn't do anything. So finally, we were able to see some granulomas, and with the history, we treated him, and he did okay. So you have to get the history. Most commonly, obviously, so the puncture wounds. Again, they usually, if IND cultures, you never IND a foot. You never touch a foot without knowing vascular supply and neurological status, right? ID doctors are thinking people. We never ask surgeons to do anything without thinking through it. You never touch a foot without knowing vascular supply and neurological status. If not, you're not a thinking doctor, and you're a bad doctor, okay? The first thing is that things have to heal. If you do not have blood supply, you cannot do surgery on a foot, whether you had a puncture wound or whatever happened to that foot, because it won't heal. So, but most of these injuries, most of the contiguous osteomyelitis puncture wounds are happening on young people that have good blood supply, children, young adults, construction workers, that kind of individual. So fortunately, those always have good blood supply, and the only thing that you really can add is make sure that they're not smoking, and you have them quit smoking, and you talk to them about that, and you document that you told them not to smoke. But puncture wounds, so you IND, you get a culture, you put them on IV antibiotics, and most of the time they will do well. The post-operative contiguous osteomyelitis is usually what happens is you have like the fracture that got an open reduction internal fixation, and now and fractures come in two kinds. They have open fractures and they have closed fractures. So the open fractures are the ones that basically the skin broke and there it comes, and the closed fractures are those that you fell and there was some kind of injury, but the skin was intact. We're going to talk a little bit about the management of fractures, but basically most closed fractures are handled by having by getting a closed reduction and then putting a cast. Those cannot get infected because you kind of like manipulated it, put a cast, and you're done. Great. But some of those closed fractures, in order to fixate them, they used to have screws and plates, so they had to take them to the OR for an open reduction internal fixation. And the chances of getting infected is small. It's probably in the 1 to 3% category, very small percentage. And those, usually if they get infected with a single organism because it was a nosocomial infection. The open fractures are a different story. The open fracture is the skin broke, the bone came out of the skin, they saw the world, they were the motorcycle accident, the bone scraped the road, the woman fell off a horse, and there was, what on the floor. I mean, so, that's a different story. So that's why we're going to talk about that different story a little bit later. But all of these things, you will spend a lot of time in the 9th floor dealing with some of these fractures. Most fractures do fine, by the way. The problem is that you never see the ones that do fine. We only see the complicated ones. So you may think that every fracture in the world gets infected. They do not. The problem is that we only get involved on the ones that have a problem. So moving right along, the problem with this kind of fractures with this kind of infection is once they occur, they're very difficult to deal with. And now the word cure becomes an elusive term. So we change our terminology. We talk about goals of therapy. Goals of therapy. So in osteomyelitis, of contiguous osteomyelitis, our goals of therapy, we don't use the word cure anymore. Now we have, as goals of therapy, we think about having a bone that is fused, a leg that works, and nothing draining. So you have a closed leg, or arm or whatever. Things are closed, nothing is draining, and you can use that extremity. That's good. Those are our goals of therapy. We're not, hematogenous was cure. Here is goals of therapy at a functional extremity, nothing draining, nothing open. That's what we're looking for. And a lot of times you have this recurrent problem. You have the person who had the fracture and they got infected originally, you treated them and everything went to sleep and the leg looks great and blah, blah, blah. And years go by. And 3 years later, they show up with a draining something. So now you have this chronic problem. So you go back to the OR, you clean it, you put it to sleep, you keep it quiet. So it a lot of times becomes a chronic problem. So sometimes the first event is acute, other events are chronic with an acute exacerbation. So we call it chronic osteomyelitis with an acute exacerbation. The problem is that you have these indolent courses. They come and go. If you see a sinus tract, and when you have seen a sinus tract, you can recognize it. Usually, you can see a sinus tract on people that have had infections in the past, and all of a sudden they don't find. All of a sudden they show up to your office, and they have this little raised purple. They almost look the purplish color that is soft, and that looks like it's going to explode soon. They look like a little localized abscess, and you know that's going to start being, and then they start draining, and that's how a sinus tract is developed. That requires, you don't have to hurry up and put them on antibiotics. You need to talk to the orthopedic. They may need an IND, cultures, IV antibiotics to put them to bed for a little bit. To top it all off and to confuse the issue even more, once you have disturbed the circulation of an extremity, like for example, in a lower extremity, you have had a tibia fib fracture, and that leg is never the same size as the other. So all of a sudden, it's always this concern about, are we having recurrent cellulitis because we have a chronic lymphedema, or is it because we have osteomyelitis? And those things are managed totally different. That requires experience. Because remember that any leg that is swollen for whatever reason, because you took out a vein to harvest for a bypass surgery, or whether the person has had some lymphatics taken out of the inguinal area, whatever, any leg that is has lymphedema, meaning more swelling than the other, has a high risk for recurrent cellulitis. And so if in that leg you had somebody that had osteomyelitis, a lot of times, and that's where experience comes in, and communication with orthopedic comes in. A lot of times a plain film can help. I am not, like I have told you many times, I'm not big into all these scans. I just do, on this setting, plain films to see if hardware is coming loose, if there's an obvious lucency, if there's something that needs to be cleaned up, that would help. A lot of times you end up treating them for cellulitis, see if it quiets down, and if that doesn't quiet down, stopping antibiotics, and then doing surgery later. So those are a challenge. I encourage you to discuss those when you see cases like that, because they are difficult. Most of the time when you do have osteomyelitis, is more prominent. There is drainage, there's something that opens up, there's sinus. Just plain little bit of swelling with little bit of redness is more indicative of lymphedema with cellulitis. The diagnosis can be very tricky on osteomyelitis. I just told you. I mean, it is at times, I'm talking to the orthopedics on the phone trying to figure out what we're going to do. The blood cultures, I can guarantee you they're negative. This unheard of. I wouldn't even order them. The white count, it's going to be normal. The SED rate may or may not be elevated. The CRP, the same. X-rays, plain films can help you probably the most. Personally, I don't use bone scans in this setting, or indium scans, or any scans. I look at the leg, do plain films, talk to the orthopedics, and that's what I do. And then we make a decision. That's it. That's what it takes. And it's a communication thing and experience. That's how you move for that. I am not big into doing any of the other things. And then, and you're not in a hurry. Nobody's going to die of osteomyelitis. And you really need to be off antibiotics for a while. If you're not off antibiotics for a couple of weeks, your cultures are going to be worthless, and you're never going to get that patient better. So a lot of times we see them, some primary care have put the patient on antibiotics. I mean, they didn't have bad intention. It was they were trying to please the patient, or they didn't know what to do. So we take them off antibiotics. We discuss with the orthopedic, and then things get scheduled 2 or 3 weeks down the line. So bone cultures are a necessity on this, and then we look at only bone cultures by histopathology to help us decide what we're going to do. A lot of times you have to make sure that just not fluid is collected, but the bone is collected. And we're very spoiled at Tampa General because we actually know how to culture bone. We know that to culture bone correctly, you need 14 days, and you have to decalcify and do some other things. Most hospitals only keep cultures, intraoperative cultures, for 48 hours, and I can guarantee you that a lot of things can miss, and we have a difficult time with that in many cases. The therapy on these cases, again, is very difficult. We have to focus on our goals of therapy, which are usually, again, no drainage, the leg getting healed, and there's a lot of relapse. And it's a kind of like, to get it fixed, you have to understand orthopedics. It is a joint effort between ortho and ID. You have to understand what dead space is and flaps and all these things. And you have to really balance hardware and stability. And I'm going to see if I can find, before we go to the other one, I wanted to change to the area where we talk about open fractures, which is kind of like later in the, I wanted them to, I was trying to fix this last night and I kind of gave up on it, so. Okay, so here we are. So we're going to do this and then we're going to go back. So just because we're here close, we're going to do the close, the fractures being close and open. So we already told you the difference between, what the difference is between closed fracture and open fracture. You all know what that is. Now, a closed fracture, basically you're going to, most of the time, you're going to kind of like manipulate it, put a cast, and that's it. Some of them require open reduction, internal fixation. And there's some controversy of how quickly that should be done. A lot of orthopedics like it early. If it gets swollen already, the leg, they wait until the swelling is down, then they do it. So it's either done very early or a little later. The swelling has to be down. You cannot do surgery through inflamed tissue. That doesn't work. But, all of those things. But at the end of the day, you're talking about a perioperative antibiotic only, and this is nothing more than any other surgical procedure in which you're putting in hardware. And basically, you open it up and they stabilize it with plates and screws, and that's it. And you're done. All the antibiotic that matter is that pre-op antibiotic you gave them. And when they close them, the patient is either not going to have an infection or is going to have an infection. You don't need to give them any more antibiotics. More antibiotics are not going to help. Nothing is going to help. It's just a perioperative antibiotic, you're done. And that patient is going to be fine or is not. And most of the time, they're going to be fine. 98% of the time are going to be fine. They're going to heal, and that's the end of the story. But that 2% of the time, there's going to be a problem. The patient is going to come back. They're going to come back to their orthopedic with pain and not healing, and the whole thing is going to be delayed, and there's a problem, and they're going to figure it out, and blah, 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 and they're going to give it some time to see, and eventually the patient is going to show up to the hospital saying, and the usual diagnosis is going to be, oh, I had a fracture 6 months ago, 7 months ago, or 3 months ago, whenever months ago, and now my bone is not healing. And you're saying, that's what the patient says, that it's a non-union. And a non-union can only be 2 things, okay? There's only 2 things that a non-union can be. It's either a mechanical problem, and he needs more plates or screws, or it's infected, and he needs antibiotics. Now, could you please tell me in which way a bone scan or an indium scan or any scan is going to help you? You're still going to have to go to the OR for more screws and plates or for infection. Debridement and IV antibiotics. So we spend a week and a half doing indument scans and bone scans. Waste of money and waste of resources and time in the hospital. So you have the non-union. So now you either have a mechanical problem or you have an infection. So the patient goes to the OR. In the OR, they look at it. They take out they do what the surgeons do, which is take out their metal or change things around. Sometimes, they have to put like an outside fixator for a little bit so that you can clean up the infection. And then there are other issues that come up, which is there may be a little space that needs to be filled in, and there are dead space issues. And you have to understand that sometimes they have to deal with those things, because you cannot put a bone, for example, you cannot put a bone graft in a place that is infected. That area the infection has to be controlled. But if there's a space there, they may be able to put the beads. And I have a picture of beads, because some of you didn't know how beads look like. But and actually, beads are available commercially in Europe and in the US. They have to make them in the OR. So they have to fill them up with beads. They have to do some things to give time to the infection to be controlled so that they can come back and fix it later if it's an infection problem. So basically, but actually, usually, if it was a closed fracture, because it's a nosocomial process, most nosocomial processes are one bug. So you have an organism and you're going to deal with it, which is a lot easier than when you have this open fracture, which you have these polymicrobial things. So so now you're going to go into the 6 weeks, IV antibiotics, 6 weeks. The patient is going to have multiple procedures. It may be that the first procedure is to clean it up and give IV antibiotics, and other procedures to fix it later. And again, it all depends on the fracture and how they can stabilize it. Sometimes it's a fracture that they have no choice but to put, even though it's infected, to put more metal. And you may have to suppress that patient. You may have to give them IV antibiotics, oral antibiotics until everything heals. And then eventually you have to take out all this hardware a year later. And then take care of it. So, you cannot demand that an orthopedic surgeon, it's never going to the infection's never going to go away without you taking out the metal. That clearly, when you say those things, what you're saying is that you have no clue what you're talking about. Because when it comes to stability and infection, you have to stabilize a fracture. You cannot leave a fracture unstable. So that is priority over infection. And a lot of times, you need to work with the orthopedic to let him stabilize it or her stabilize it. Then you treat the infection acutely, suppress until you can then things heal. Then you can take hardware. Then you can do that. And sometimes that takes months and may take a year. But that's where communication, professional people talk and do the right thing for the patient. It may be very different and it's individualized. So you have to understand how you have to talk to the orthopedic surgeon to do that. Okay, so those are for closed fractures. For open fractures, most open fractures come from high energy trauma. Most of these things coming on patients that have had a lot of associated injuries. The statistics are that 50% of patients that have open fractures have associated injuries like intra-abdominal, chest, skull, pelvis, or major blood vessels. You can understand how a broken leg is not the priority. Okay? The patient comes into a trauma alert and they have a ruptured spleen, a ruptured whatever. The fracture is going to get kind of like propped up and hung from a pole, and that's it until they get to it. Until all the, really, it's just like, it is a reality. So this is this is you have to understand where these patients come from. By the time you see the patient, this is the kind of patient that has been in the hospital for several weeks, and then they call you. They have this cold thing, this, that, whatever. They have multiple things. So there's a lot of, then the other issues is that a lot of neurovascular problems may have happened in the extremity. You may have had, so you always have to, but again, you are a bad doctor, and I keep on, it is I feel like a broken record. Whenever you look at whenever there's any ID process in any legs or arms, you always look at blood supply and neurological status. That is like so key to understanding all of, and what you're going to do. And if you don't do that, when you talk to your colleagues, they realize that you have no idea what you're saying, or that you are really you're not at the level that they are, and then you lose credibility. And that's the professional thing that we talked about. So neurovascular status or injured extremities. Now, some of them have compartment syndromes. Compartment syndromes are complicated because not only do I now have bone problems, but we have soft tissue issues and coverage, and the muscles will never be the same. So a lot of these things have to be taken in consideration when you're talking about open fractures. Now, the risk of infection is very much correlated and proportional to the severity of the injury. And I'm going to, I'm not going to tell you what a type 1 or type 3 open fractures, but obviously the more severe, the more soft tissue and the more stuff is missing, and the more complicating it is, the higher the fracture. Okay, but a type 1 fracture has a slower risk, but when the time you hit a type 3 open fracture, you're talking about 10 to 50%. Most people will tell you somewhere in the 30% category is a realistic number. That's a lot. An open fracture is a bad thing. Horrible thing. I mean, 30% chances of you developing an infection. And remember that these infections, you never talk about cure. We're talking about just doing the best we can. So the patient comes in with all these things happening. Nobody cares about what's happening to your leg. But the truth of the matter is that you really want to look at it, and the data shows that those patients that have open fractures, one of the things that they need is antibiotics within 3 hours of the, it makes a difference if you can start antibiotics within 3 hours of the injury. So antibiotics matter here. And wound debridement, and obviously a tetanus shot needs to be given. But you have to wound debridement, meaning that literally they take these people to the OR and they clean the hell out of it, everything that looks bad. Because these people have had exposed to cement, to asphalt, to dirt, to everything on the name, depending on where was the injury. So these things have to be cleaned up aggressively, and they go to the OR like every other day for a few times until the surgeons think that things look good. Okay, and it's usually in polymicrobial, gram-positive, gram-negative, anaerobic. Most of the orthopedic literature talks about and they still use that cefazolin, gentan, amp. Cefazolin as a gram-positive, gentamicin as a gram-negative, and ampicillin for anaerobes, especially Clostridium. These days, especially if the patients are in trauma services and things like that, there may be some other combination of whatever they're getting. But what you want is some gram-positive, some gram-negative, some anaerobic coverage. One alone is not going to be enough. But if you look at all the old literature, that's what they were talking about because of that reason. So ignoring the extremities is a problem, and a lot of times this is why these people end up having so many problems. And you can't blame people. When you have a ruptured spleen, a broken leg, it's not a big deal. Everything in life is priorities. But you have to realize that these are the things that make a difference. So there are other ways in which. So now you cleaned it 2 or 3 times. You have cleaned it very nicely. Everything is clean. It was a grade 3. You got your all of those things. But the problem is now there's a piece of bone missing in the middle, and it was all dirtied up. And you have soft tissue missing, and they had to figure out how to put this thing together. Nobody's going to put a bone graft in the middle of all of this. So the soft tissue is usually handled by local grafts, which are called rotational grafts, or free flap graft, where they take a piece of meat from somewhere else and put the steak in top of the thing so that you can bring blood supply, because you can't fix anything in medicine without blood. Like the grass doesn't, unless you put water, the grass doesn't grow. Well, nothing grows, nothing gets better unless they have blood. So you have the piece of bone open. So they have to come up with things that they can use to fill out holes, because if you have a hole that is empty, fills up with fluid, and anything is static, bacteria grows, right? You leave a piece of some water out there stationary, it's going to grow bacteria. So somebody has to put something in there. So that's why they put the beads, they put the flaps, they do all these other things. And you can make beads from aminoglycosides, from vanco, from cephalosporin. They have to make them themselves. And I'm going to tell you how to make those in a little bit. But so the wound management is really important. They have to clean these things. They have to irrigate them. And this, for example, in some of the literature, just to tell you what these people are doing in the OR, because they're going for an IND. Well, they are going and they're getting these things cleaned up the best they can. Sometimes there's literature. In the literature, there's suggestions of 10 liters of saline with bacitracin, with polymyxin. They're doing the best they can and trying to close that wound, and then coverage with local local flaps and leaving like beads in there, and so that they can deal with the dead space. And eventually those openings, so a lot of times what you'll see is these closed fractures early on. They get a lot of debridement, they get antibiotics, they have beads left where the bone graft eventually is going to go. They put a big flap, usually a free flap or a local flap. They have to put the skin graft on top of it, and then they say, okay, go home on IV antibiotics, and then you take care of them, and then they come back 6 or 8 weeks later for a bone graft now that the infection is all taken care of. And then the first thing that they do is they go back to the OR, they lift up the flap, they take out the beads, and they send you cultures and pathology, because they don't want to put that bone graft until 3 or 4 days later when they see that everything is clean and they're consulting you. You're not sure what they're doing. They're doing the right thing. You're the one that doesn't know what's happening, but they know. They know that they don't want to put that bone graft until things are clean. So you'll see these things happening up on 9C, and hopefully this lecture will give you some idea of why they're doing what they're doing. So the bone grafting cannot be done because once bone grafting is done, they need hardware, and they can't do it until later. There are ways of fixing fractures, which is for open fractures, you can, or sometimes, for closed fractures, but you can put intramedullary rods. External fixators are used a lot of times when you have things that are very dirty to keep a stabilization and until you can come inside, but then you have to deal with the pin infections, and pin care is very important. And actually the method depends on where the bone is, how you can stabilize it, how much soft tissue injury was there, and sometimes even the expertise or the place where it's being done until the patient can be sent to somewhere else. Bone grafting, most of the time, is not done until 6 weeks later, and everything is clean and the soft tissue has been dealt with and all of those things. And a lot of times you see this happening, and when they come in for the bone grafting, there'll be like 2 steps. They'll do one time to look and make sure everything looks clean. They give it a few days to make sure the cultures are negative. Then they go in to do the bone grafting. So don't get desperate and wonder what they're doing when they're doing those things. So what do you do with antibiotics in open fractures? Well, early is important. You don't have to go too long, 3 to 5 days. Most people say that is enough. And every time they do something big, like bone grafting, wound coverage, all of the things, they need more antibiotics. And if anything looks really infected, then it becomes really osteomyelitis. Then you treat them like you have been told to treat.